This is an antiplatelet, antithrombotic talk on PAD and CLTI. At the end of the day, all my disclosures, which really created so much difficulties for talking at the meeting, are absolutely not germane to this talk. General considerations, when we talk about therapy for our patients with PAD and CLTI, you're going to talk, at least internally, with antiplatelets, statin. There's a ton of information on statins and the pleiotropic effect, as well as the pleiotropic effect for ACE inhibitors and ARBs, which again are the anti-inflammatory responses. And the diabetics are really going to push glycemic control. Without a doubt, anybody who is a smoker, you're going to pound into their brain that they need to quit tobacco. And then for all CLTI patients, it's not a one and done deal, as you already know, when it comes to the revascularization strategy, but you're going to do a lot of local foot care, got a lot of hand holding, and trying to cajole these people into continuing their therapy. This talk is specifically going to be only on the first topic, which is antiplatelet. If you look at the guidelines from 2016, when it came to aspirin and P2Y12 or the ADP inhibitors, level 1B and level 1A evidence for the use of antiplatelet agents, and that still holds today. The guidelines changed in 2024, which we'll get into. This is from Hirsch and colleagues and Deepak Bhatt, which is the comparative benefits of clopidogrel. So this is the Capri trial. This is why ADP inhibitors have been used in addition to aspirin. Remember, ADP inhibitors do what aspirin does, but just without the risk of the bleeding from a cyclooxygenase or inhibition, so you don't get the gastritis. But they're very, very good at inhibiting platelets. And if you looked at aspirin versus clopidogrel, the cumulative effects of complications were lower with the clopidogrel, which is why Capri was a positive study. When you look at optimal medical therapy as you move forward in the antithrombotic realm, our goal is to try to limit outcomes of either stroke, heart attack, or peripheral arterial disease. And so whether or not you're just doing it for CLTI, it has a greater umbrella of what it's trying to effectively treat, which is the inhibition of progressive atherosclerosis. The AHA guidelines were updated in 2024. There are 10 points that they mention as to what's beneficial, what's changed from the 2016 guidelines. So number 5 is effective medical therapies for patients with PAD should be prescribed to prevent major adverse cardiovascular and major adverse limb events, to include antiplatelet, generally single antiplatelet, and antithrombotic therapy. Lipid lowering, as we just described early, and then really tight control of diabetes and smoking cessation. So this is where the guidelines, what we're going to focus on now for the remainder of the talk. This is a busy slide. It looks really, green is good, yellow is kind of not so perfect, and then orange is really take a look at it before you do it. If there is revascularization versus no revascularization, this is where the separation in this algorithm comes from to really blow up that one segment. If there's no revascularization, you can do single agent or you can do antithrombotics. If they have recent revascularization, then dual antiplatelets are going to be useful. The duration of that is really up to you, not up to the guidelines. And so we still have to make some decisions with our patients as to what we offer and how long we treat. When you look at, forgive me, excuse me, if you look at antiplatelet and antithrombotic therapy in the guidelines, level 1A in patients with symptomatic PAD, these are not just CLTI patients, single antiplatelet therapy is advisable. That would be aspirin or Plavix to avoid MACE, and that's a 1A indication. 1B indication in patients with symptomatic PAD, single antiplatelet with clopidogrel alone is also recommended to reduce risk of MACE. So it's either direct platelet inhibitor, i.e. aspirin, versus clopidogrel. This would be coming from Capri. When you move beyond that, in patients with symptomatic PAD, low-dose rivaroxaban, now we're going to get into the two trials, which are Voyager and Compass, have now made it into the guidelines. And so low-dose NOAC by way of a factor Xa inhibitor, rivaroxaban, combined with low-dose aspirin, helps reduce not only cardiovascular events, which was the point of Compass and Voyager, but also MALE. And so it gives you both the cardio as well as vascular outcomes that are at level one, class 1, level A evidence. After endovascular or surgical revascularization, antiplatelet therapy is recommended, and that includes level 1B evidence. When it comes to antiplatelet therapy for PAD, the 2s and 2Bs are listed here. Generally, you don't want to overdo it with the antiplatelets. Again, the risk of antiplatelets, and what you'll see when we go through Voyager, is that as you add antiplatelet agents become more significant when it comes to thinning out the blood, i.e. low-dose rivaroxaban. It comes at a cost. No matter what we do, it's always bruising and bleeding, and that ultimately is the point here. And then what you should not do in patients with PAD without another indication is go to full-dose antithrombotic therapy, i.e. full-dose rivaroxaban or any other NOAC. This is from Banaka, Mark Banaka's paper. This is the original meta-analysis and analysis between the low-dose rivaroxaban and placebo, and clearly there's a benefit of reducing MALE or the cumulative incidence of major cardiovascular events to include MALE with the addition of rivaroxaban. So when it comes to overall antithrombotic therapy with PAD, clearly primary and secondary prevention are our critical methods of therapy for our patients. No matter what you do, no matter how you do it to make patients better, whether it's cardiologists like me doing coronary work or you're doing PV work, the secondary prevention, the antithrombotic events that you're trying to stave off on progressive peripheral arterial disease in our patients with atherosclerosis is critical. It now has level 1A evidence, not only for aspirin, but for the dual therapy of rivaroxaban, low dose, that is the Voyager trial, to limit your patients' outcomes when it comes to both cardiac as well as vascular issues. The general guidelines advocate class 1 level of evidence A for antiplatelet, antithrombotic therapies for the benefit of the patients, to include, and this cannot be understated, what you do in PV still affects life and limb. And so we already know if we salvage a limb, we salvage lives, right? But now by just doing the simplest things as a physician to take care of your patients, but simple antithrombotic therapy, you will also limit risk of mortality and but morbidity of limb loss. Primary and secondary treatments in the combination with revascularization strategies really do offer the best options for our patients with significant and symptomatic PVD. Thank you for your attention.